Gentlemen, please put your hands together and let's listen to the AMR expert. Over to you.
Hello. India is rising, so is antimicrobial resistance. You agree with that?
Yeah.
Right. It's a great honor and it's a great day to be here because it brings under the same roof two people. One is an antibiotic discoverer, Father Inasimuthu, who did half his work in my hometown of Tirunelveli, and my colleague and friend here, Maneesh Paul, who is a co-discoverer of N-metasobactam, the magical salt which can inhibit beta-lactamases in drug-resistant bacteria. So we're going to discuss back and forth what antimicrobial resistance is and what are the alternatives we have today to combat AMR. It's a very, very serious problem. Probably I would say this is the greatest global health challenge of this century, and we don't have an answer. So by 2050, half the deaths in medical centers due to pneumonia, post-surgical complications, and even a simple process like tooth extraction can become lethal because half the drugs, antibiotics, antimicrobials are going to be resistant and pathogens are going to have a field day. So how do we even go about this? Our options are very limited and the adversary is really, really strong. So several years ago, the word antibiosis was started and slowly antibiotics were discovered. It was soil microbiologists like Father Inasimuthu to Selman and Waxman, and even the penicillin mold was a soil fungi which really created the dawn of antibiotics. In the World War II, the Anglo-American approach was used to a fungal extract to combat antimicrobial processes, and the Russian approach was to use bacteriophages. Somehow the fungal approach took precedence because it could be used systematically, and today we have a plethora of antibiotics. So over to my colleague, the co-discoverer of N-metasobactam, to give us the industry perspective of do we have new antibiotics? When is the new antibiotic coming? Why is it so hard to bring out an antibiotic? And what are the antibiotics in pipeline? Because everyone asks, what is the new antibiotic? So over to you.
Thank you, Dr. Gifty. Just last week I was in Delhi and I've been traveling around the world and I thought my immune system is so good. I would never get affected, but my one trip to Delhi got me lied down. For now almost like 8 days I've been down with a throat infection. My voice is still coming back to me. It's not fully back. So microbes don't spare anybody. We know that, right? We may have, however, how much ever money is invested into the armed forces or in building the human man, in human capital, in combating wars, and etc. Just these invisible microbes can decimate all our efforts. And the only path we have is the antimicrobials. And in fact, when antimicrobials were invented, that is the time when India got independence and we are grappling with the huge health burden. So obviously what happened, we had to save lives. So antibiotics were probably, I assume, were popularized so much that everybody started taking them, with a lot of ignorance because it extended the lifespan. In olden days, I think Shashtabdi was the largest, birthday celebration, huge. Then we went to 80s. Now I think centenarians is not going to be a big deal, provided we save the existing antibiotics. To your question on why it is difficult, I'll tell you. N-metasobactam, this is the first ever and only India-invented antibiotic to be approved by US FDA so far, which got approved in 2024. And that's my baby, right? So it took 18 years. So I call it, it's like 2 gestational periods in years, not months. It takes that long to bring a drug from idea to the market. When we know that it takes such a long time to bring a drug to the market. If we draw the parallels of the way we are abusing the antibiotics and the way we are bringing the new molecules, it is completely inversely proportional. So if we do not save the existing ones, I think we are heading to a huge challenge. Because drug discovery has multiple phases, and most of the molecules which are invented or discovered, they would not see the light of the day because of safety and the propensity of developing drug resistance at what pace. So what we do in a drug discovery is we fail early, fail fast. And when it comes to the regulators, they are very strict about safety. Obviously, safety is the one which drives the regulators' agenda. But to bring a drug from a molecule or a structure, bring in the properties which are drug-like properties, and then make it compliant to the regulators' expectations and convert them into a product that could be sellable and make return on that investment, I think that's a real challenge. And the challenge comes because of two things. One is the investment which goes in, and the returns are so low. In any other therapeutic area, like you've got metabolic disorders or hypertension, any lifestyle disorders, once a patient comes in, he's a permanent giraki for a long time of her life, right? He keeps consuming the same drug over and over. So the drug company would definitely make a lot of money. But in case of antimicrobials, it's anywhere from 3 days, like for azithromycin, and up to maybe 21 days. Very rare cases it can go for long-term infusions. Otherwise, not long-term treatments happen. So the ROI is very low. Because of this, most of the larger pharma has stepped away from drug discovery. And it's the smaller biotech which are coming forward to do this. Now, I would hit a question back at you, because when I've explained to you how much of a challenge it is to bring a drug to the market. Now, as a clinicians, I mean, this is a hospital setting, of course, and most of you are, coming from modern medicine who prescribe antibiotics. Now, you being an ID specialist, how do you think you can increase the timeline before we get the next resistance into the market? Because bringing a new drug is so challenging, and if the resistance is coming faster, how do you think as a clinician you can contribute in extending or deferring this resistance from coming back?
I think that's a metaphorical question. The first and foremost, we as clinicians in medical schools throughout India and many countries, we are trained in antibacterial microbiological management, antibacterial therapy. Paul Ehrlich, the father of chemotherapy, several years ago called these as magic bullets. So we tend to feel antibiotics are very powerful panacea, and they can be given for all disorders. So in a country like India, without much of regulations, self-medication, the medical shop prescribing antibiotics, and again and again using the same prescription. In the Western world, they put a seal saying cannot be used against, once dispensed. We don't have such things. So first thing is our education system teaches a lot about antimicrobials, particularly antibiotics, and we have little training on antiviral chemotherapy. I was discussing with one of the panelists that most of the infections which we see now currently in Bangalore, for instance, are respiratory viruses. These are metapneumovirus, respiratory syncytial virus, non-COVID viruses, recombinant influenzas, and many of these viruses. The first thing, you go to a doctor and they put you on a particular antibiotic. In fact, I can even mention the brand. It's called Augmentin. And in medical circles, we call it as augmenting addiction, just like amphetamine addiction. So Augmentin really doesn't work. And it does work in bacterial infections, which are secondary at a later stage of respiratory viral infections. But there are a few molecules like nitazoxanide, the world's first pan-antiviral drug, which started as a parasitic drug. Today it's very much available. You can boldly use it for any respiratory ailment which you clinically suspect is due to a virus, and that will bring down the viral load, the sequelae, the complications, and also the requirement for antibiotics during a secondary phase of the viral infection. So these kind of paradigm shifts in our guidelines are required. For example, just before coming, I was going through CDC's guideline for post-sexual exposure between men who have sex with men in the Western world. They recommend 200 milligrams of doxycycline. Won't it cause resistance? It would. Because gonococci, one of the leading STIs or STDs, is already resistant to a plethora of antibiotics. So these kind of post-exposure prophylaxis, single dose, we have a drug called baloxavir, and this is recommended as a within 48-hour single dose drug for flu, that is lethal recombinant flus. So once you go on these kind of PEP or PREP protocols, they can also produce resistance. So I feel, to lessen the burdens of all the clinicians here, we are not the only culprits. We are one of the culprits, but not the only culprits. The larger section happens in the industry, in particularly livestock industry, veterinary industry, and even in pipeline industry, where tetracycline is used to reduce biofilms in large pipes. And these kind of usages contributes more to environmental presence of these antibiotic disruptors or sensitivity and resistome building, like human microbiome. We also have something called resistome. So the resistomes keep building, because even before the discovery of antibiotics, I would like to highlight there was antibiotic resistance in even ancient Paleolithic microbes. They are always at an eternal race. So Alexander Fleming, who discovered the archetypical antibiotic penicillin, said that soon there will be resistance. And even within 2 years of discovering penicillin from its commercial strain notatum, from Chrysogenum, there were resistance in London hospitals. So this is expected with any antibiotic, even if you use it rightly. Because of many, many reasons which will be beyond the scope of this discussion, antibiotics will become eventually resistant. The only way to manage this is stewardship, reducing unnecessary usage, and also substituting the right chemotherapeutic agent instead of antibiotics for everything. So do you agree on this?
Yeah, I do agree. But when we look at environmental factors, right? I would say it is not only antimicrobials that are released into the environment that are causing resistance, because we test the compounds that are generated or synthesized or isolated for antimicrobial activity. Only those are tested against antimicrobial activity. Not everything, right? So which means the food additives, the drugs made for other therapeutic areas, even they precipitate antimicrobial resistance. In such situations, I think stronger regulation across pan industry is necessary to make sure that what kind of foods we eat that alter the gut microbiota is also very important, in addition to the environmental pollution. Of course, I do agree, it is not the clinicians are the only to be blamed. I would blame also the pharmacists. And sometimes they are right, for all you know. Because in the Delhi airport, when I went, I told I'm getting already itching in my throat, I'll take some cough lozenges or something. He said, "Kya hua aapko? Thoda dard ho raha hai." He immediately took out and gave me azithromycin. I said, "No." I showed him my lapel pin. "Do you know what is this?" "It is prevent AMR." He said, "Sir, wo to hai, magar main bata raha hu na, yahan pe yahi chalega." And I said, "I'm not going to use it." I wanted to prove I was right, but after 4th day I had to take azithromycin out.
He eventually succumbed to it.
So this is what happened. And I mean, that's jokes apart, but I think it is wrong for a pharmacist to prescribe an antimicrobial agent. I think they are contributing significantly higher, contributing towards higher AMR for the simple reason they would see what clinicians are prescribing in their area, and they know this. Okay, we have Dr. Gifty prescribing this X, so they start prescribing. So I think we need to strike a balance here. More than the clinicians and the pharmacists, if we can bring in community stewardship, if every human being, we think we are here to fix the earth, the planet. After we mess it up for 200 years, with industrial revolution, and we think we are trying to fix it. I think we got to take a step back, and everybody should realize microbes are mightier than human beings, and most of our body is composed of microbial population of diverse species and genera. Respecting the microbes becomes very important. Once people realize it, many of them don't even know that our major composition is microbes. I think community stewardship is what I would encourage more than, just putting policies and etc.
That's definitely a welcome change, but very hard to implement at the community level. Another issue with antibiotic overdosing is not just resistance, it's also development of Clostridium difficile diarrhea. In the Western world, I'm sure it's huge problem. Dr. Sundar Swaminathan will agree, especially in their ICUs and other things. It is resistant to average hand gel, so you need to wash it to lavage it from your hands, and it's usually a huge problem, CD diarrhea or Clostridium difficile diarrhea. So we kind of recolonize the intestine with probiotics and even engineered probiotics. Then another issue is the use of drugs like antibacterial soaps laced with a lot of drugs like triclosan and other things. This can also aid to what we call as resistance. Because if you look at the Darwinian selection pressure, if any microbe, you put them under selection pressure, resistant strains will come out. There was one very interesting finding. Hedgehogs or porcupines, when they are infected with normal Staphylococcus aureus, and they also parallel or co-infected with a dermatophyte, this Staphylococcus aureus can after some time become MRSA, methicillin-resistant Staphylococcus aureus, because within the same organism, you have a dermatophyte which is partially killing the microbe, which is a selection pressure, and an MRSA comes. So in travel medicine and wilderness medicine, I saw a travel medicine clinic board outside in St. John's. The recommendation is whenever you have a wild animal bite, suspect MRSA or a resistant pathogen, because these will harbor resistant pathogens. And another interesting Israeli finding I saw was even plants, this is something I could discuss with Father, do bioterrorism by lacing their thorns with a lot of resistant microbes. So any animal would get punctured by these thorns will eventually develop a lethal wound for which they will die and never come against the thorns again. So in nature, these antimicrobials are at a constant war. We are using one of their strategies for a short time, but eventually these strategies will be exhausted. So the answer, I think, in this scenario is to use alternatives. Like, for example, there are gels made of nanosilver. Nanosilver is very strong and it is effective against a lot of pathogens. Adjuvants like glass bead-based gels. These gels can replace antibiotics. And also to use phages, bacteriophages, which can kill bacteria. And these have no resistance. The only problem is they are not used systemically, but it can be used topically. There's a Bangalore-based company called Ganga Phages, which is working on it. And one of the reasons Ganga is supposed to be self-purification is because of the presence of large amount of environmental phages. So these kind of radical approaches need to be done than relying on antibiotics alone. And even during pregnancy and delivery, if someone is infected with the Streptococcus bacteria, we give them antibiotics, beta-lactam. The child is born with a disrupted microbiome. The microbiome which we are supposed to get as a maternal gift gets disrupted. And there itself, there is a shift in all these patterns of healthy bacteria, probably like lactobacilli, which can prevent even against the acquisition of HIV, is reduced and modified. And a lot of immune procedures which we do, like immunosuppression and alterations, transplantations, all these things can cause a huge shift in our microbial population. Now the point is, where do we go here from now and how do we manage this?
So I would encourage more on conservative approach. When a patient comes with an infection, our tendency is the fear of losing the patient from our clinic. I think that phobia should go because there are enough number of patients available in our country because the proportion between the clinicians and the patients is highly skewed. So there is no fear or dearth of patients for us. We're overworking, clinicians are overworking. So that fear should go away and they can leverage that opportunity to tell them you don't need it. You can go back home, take 5 days rest. You will be fine. It's not going to hit you unless there are some comorbidities or underlying predisposing conditions. Those conditions are one thing. The second is, how do we strengthen our immune system? Normally what I do is, the moment I get this itching, I take a concoction of this, samahan. I start off with the samahan so that starts preventing me from getting infected. That's how I could sustain for 3 years without any infection. For Delhi, I tried to be a hero, so it made me into zero in no time, microbes. So I didn't take samahan the moment I got the symptoms this time, because it didn't carry with me. So that is one thing. Building and strengthening the immune system is better. As I heard the panelists earlier, they were mentioning is, how I think treatment came as the fourth option, what he mentioned, Rajiv, right? So fourth is the treatment, not the first one. But here, because we have access and the price control is so strict that it is so easily available. So people are just going and popping in this like crazy. That has to stop. So education on building the immune system, like the Compeer, master of ceremony, she was telling that Ajimane, Ajimane Uta, Jadi Bootiya, what we call it as, But we have got TDU. I've been there several times and met you, Dr. Darshan, there, along with Prasanna as well. And when I was an Acharya, I used to come to you. So develop something against antimicrobials for fighting AMR. That was almost a decade ago. I came and discussed with you a long time ago. The thing is, how can we bring in integrated approach in addressing AMR? Now, this is an amazing platform.
Exactly.
I think diverse people are here, and this can become that think tank and not just remain on a paper or on a video or on a policy document. How do we replicate and transmit this information of bringing an integrative approach towards? And why I like to go to Dr. Gaurang, I mean, he literally floored me when I saw his whole approach. I said, this is the right approach to, cure the cause than treat the symptom.
Exactly. One Westerner told me, alternative medicine is alternative to us, not to you. For us, it's the mainstream medicine. It has brought us 5,000 years. I have no resistance or any kind of reservation in saying that. For that matter, I worked on a very good antiviral called Phyllanthus amaris, which is taken from Keelkainali, which is a traditional herb, with Professor S.P. Tyagarajan. And he, in fact, published this with a well-known Nobel laureate, a Jewish Nobel laureate called Baruch Blumberg, discoverer of hepatitis B, and this particular drug was much better than entecavir and tenofovir, all the anti-hepatitis B drugs, and it did clear the virus much more quickly. It had something called as phylanthin and L-G-tannin, and these was able to inhibit the viral polymerase much more effectively. So we can integrate. India is the only country where we can integrate traditional know-how with Western medicine. In fact, Harvard has got a residency program in integrative medicine, and final year they have things like moxibustion and acupuncture. India tried to introduce these programs in Western medical schools in India, but there was a lot of resistance, not antibiotic resistance, social resistance. So we shouldn't shun our own systems of medicine. There are great things, as mentioned earlier. East European herb extract is metformin, and most of our drugs from D-tuberculorin to atropine are from plant origin. So we already have a phyto series running in allopathic medicine. So there is no harm in adding more. And another interesting thing is, I had a recent meeting with the WHO Variola Committee. There are only 2 drugs for smallpox. The first question my mom asked to us, you are working on a disease which is no longer there. But the answer is, they feel due to bioterrorism and synthetic biology, smallpox can come back. There are some vials, clandestine storage is there, and by sequencing, you can really create. In fact, they created Tanapox and Horspox. Now, the point is, if it ever breaks out, there are only 2 drugs, which is cidofovir and brincidofovir. But I also found an interesting thing. Traditionally, Red Indians used to use a plant called a pitcher purple plant, and this plant had a 100% cure rate. These are anecdotal reports in literature. If this plant can be made into a drug, It can be the third drug in the armamentarium. So we are not against such approaches, and it could also give us some leave space or a leverage against antimicrobial resistance. So an integrated approach, a rational approach, stewardship with the chemotherapeutic agents. I feel really sad that the word chemotherapy has been stolen by oncology. It belongs to infectious disease. I'll reinforce that today. Right.
Yep. Thank you. And I think we run out of time exactly. She's come to take it. So probably if we have some questions from the audience, we can interact for the next 5 minutes. I think we have 5 minutes for the interaction.
Yes, sir.
Yeah.
Need a mic.
My name is Naga Subramanian, and I'm kind of into a surveillance mode, kind of in a medtech, AI venture. So basically, my basic question to you is like, we always talk in terms of AMR whenever it is. It's only, if I get the diagnostic portion of it. Today, it's all in central, laboratories, where you try to see a area, community, medicine, and all those stuff. But what if you have something which is available locally, you are able to diagnose immediately. So this is a kind of a question we are trying to solve here in our side using AI and all that. So do you think that could really help to kind of have a diagnosis done immediate, right?
I'll answer
so
that question.
Before even predicting before even going to prescribing any medicine, do you think that's an option available for us? And if there is
It's not an option. It is necessary because even before a clinician prescribes, there has to be diagnosed 30 hours, overnight culture, and then do the diagnostics. We are looking for diagnostics which could be done by the clinician on his table so that he can convince the patient it is not a bacterial infection, you don't need an antibiotic. You can just go back home and take some rest. Because most of the patients think they have a bacterial infection. Everybody thinks anything microbe means bacteria. They don't think of virus. So point of care diagnostics is more important. Brilliant. Sure. A PACE is, I'm part of the PACE Strategic Advisory Committee, right? That's where we are talking about is funding is up to 30 million pounds given to develop a kit which could solve this problem so the clinicians are more empowered.
I think so. To add to that, we have certain litmus tests which can be done as a point of care at your clinic, where the clinician can immediately tell if the patient has a resistant profile. So you will prescribe antibiotics which are resistant on the list. This is a POCT, like a point of care tool, and even the longitude price, the UK is the largest price for antibiotic resistance, is for teams who produce such, this is for sub-Saharan Africa and India and other places, where the clinician can immediately tell if this infection is resistant, if so, which pathogen resistance patterns are there, and you can prescribe accordingly. I think that's what you've been asking. Right. Yes, doctor.
To add to that, at IASC, one of my colleagues, he has developed a methodology, it's published I think, where at 2 hours, within 2 hours of admission, you can actually take the plasma, and then with this it's able to distinguish, for example, a bacterial sepsis versus like an influenza. So this is again with AI integration and all that. So with the 98% accuracy. So I think this is exactly what is needed to avoid unnecessary administration of antibiotics.
That will be a great thing. There is already, I hope it gets commercialized, it will be lung sample, and they'll tell you within half an hour if it is a bacterial pathogen or a viral pathogen or a parasitic pathogen. Same for cerebrospinal fluid. But the problem is, it is costing 15 to 20,000 rupees. Now for a common flu or a common fever, if I am charging, I will never be able to practice anywhere in India.
Hello.
So that is cost limits us from such things. But centers like IASC and IIT come out with very affordable solutions. I hope that comes into the foray. Thank you, Professor. Yes, sir.
I have one question. This is for Dr. Maneesh Paul.
Yes, sir.
You spoke about Samahan.
Yes.
Okay.
Amrita Rishta.
Amrita Rishta, Ayurvedic one. They call it as the Ramabana for cough, for body ache, for fever. How far it is good to use that?
So there is already published literature which has done a trial, complementary support during anti-infective, during infectious diseases. There's a publication from Ceylon. I sent it to you as well, I think. Yeah, it is evidence-based. It is not just
So it's good to take.
I mean, there is literature available, so I take it.
I have 3 bottles at home. Don't worry. Thank you.
Thank you, audience. Thank you for shooting the questions.
Just one
Sure,
question.
sir.
Yeah. Incidentally, Amritaristam is also used as a prophylactic, is from a host-based approach to antibiotic microbial resistance management or reversal. What is your experience when you're particularly finding that the microbes are fast mutating or developing resistance when you go with and that battle is very tough? So is there an alternate paradigm in which we can approach the problem, wherein you make the host, which is the person or the gut or wherever it is resident, so uncomfortable for the microbe to continue to proliferate? In the process, it automatically is there because we have so many trillions of microbes. It's just that they live either dormant or in harmony, right? So what do you think about the host-based approach?
That's a very futuristic approach.
Ayurveda's approach.
Yes. I think thalassemia patients, you could administer something like colony and granular stimulating factors, which kind of stimulate the immune system to fight the bacteria, or interferon inducers like thymosin alpha, which can be orally taken. These also can trigger your immune system to eliminate it. But the understanding is no matter how good your therapeutic agent is, it is the immune system which also combinedly in a synergistic way clears the infection. So immune modulating is one thing. Recolonizing is another thing. Especially in a case of enteric fever or typhoid, we kind of compete with the intestinal bacteria by loading them with Saccharomyces cerevisiae or lactobacilli or Bacillus subtilis. All these pathogens, healthy pathogens, healthy microbes can fight against the pathogen, competing for nutrition and space, thereby having an indirect antibacterial activity. This is one area we do. And of course, antioxidants and microminerals in HIV and other conditions are also supposed to bringing what we call as Lazarus effect. Lazarus effect in the sense restoring the immune system to a greater level, resurrecting the immune system. So that is also possible, but these are all very nascent and not in a very fully employable manner in all cases, but definitely something which can be looked into.